Thank you for the opportunity to share some high-level considerations around the conduct of this trial. Just to remind you, this is the curriculum wheel that you'll all have become very familiar with in your engagement in the HDRN program. While this is a curriculum wheel, it's also extremely illustrative of the issues that every single trial leader has to overcome or address in conducting a pragmatic trial. And so it really speaks to the realities of doing these sorts of trials. With respect to the intent and the question of Be Free, our intent was to generate information to inform everyday clinical care in cardiac anesthesia. Because in cardiac surgery, care is usually provided within very specialized centers where patients are cared for using very standardized care pathways, often in the form of institutional policies. This is simply because in patients who are relatively homogeneous in terms of their comorbidities and risk factors, who are undergoing a relatively homogeneous set of procedures where the perioperative problems and concerns are very similar from one patient to the next, care is safer and more efficient when it's conducted according to standardized care pathways. In contrast to this, anesthesia care is generally not standardized, and there's wide variation in routine practice. And so given that within the standard of care, patients may receive or not receive benzodiazepines, we felt that the most appropriate way to answer a question about routine anesthesia care was to do so through variations in a standard institutional policy with respect to the use of benzodiazepines during cardiac anesthesia. Be Free was a cluster randomized crossover trial where each of 20 participating hospitals or clusters were randomized to use one of two institutional benzodiazepine policies an equal number of times at random over the course of 12 to 18 4-week crossover periods. The trial was integrated into routine clinical care. In order for the trial to be successful, all members of the cardiac anesthesia groups in participating hospitals needed to agree to apply the two policies according to randomization in at least 90% of patients undergoing cardiac surgery during the trial period. This was one of our inclusion criteria. Because the key implementation issue was adherence to the two policies, prior to the full Be Free trial, we undertook a pilot study where we tested and developed communication strategies to optimize adherence. The intervention itself was implemented at the level of the hospital, not the individual patient. Whether or not the policy was applied to individual patients was filtered through the discretion of a credentialed cardiac anesthesiologist who could determine whether or not this was appropriate or whether there were patient-driven reasons that one policy or the other should not be applied. An example of these sorts of institutional policies already used in routine care is the use of perioperative antibiotic prophylaxis. Most hospitals will require that all patients receive some sort of antibiotic prior to surgery in order to prevent postoperative infection. However, if patients are allergic to the antibiotic that's stipulated within the policy, clinicians can elect to make exceptions to these institutional policies for patient-driven reasons. Be Free had a number of statistical considerations related to the use of cluster randomization, the large number of periods, and the large number of crossovers, as well as our mid-trial adaptation to sample size, which occurred primarily because of case volume changes resulting from the COVID-19 pandemic. These are described in detail in the trial adaptation supplement to the original publication. Within cluster randomized trials, a key statistical consideration is the loss of power as a result of clustering, represented statistically by the intracluster correlation coefficient. By incorporating a crossover, each center acted as its own control, regaining some of the statistical power that is lost because of clustering. Within a cluster crossover trial, each time a center crosses from intervention to control, additional statistical power is regained. For this reason, we included a large number of crossover periods to overcome the relatively small number of participating clusters, thus ensuring we had adequate statistical power to answer our question. Our intervention was an institutional policy to which hospitals were randomized. Clinicians determined whether exceptions to the policy needed to be made at the level of the individual patient. Because our intervention was a hospital policy and our outcome was institutional delirium rate, we would have been unable to determine whether our policy was effective if we had not included all patients, independent of whether or not the policy was applied to them. As such, the research ethics boards of the 20 participating hospitals allowed for an exception to the requirement for individual patient consent. Within hospital information, admission, and discharge packages, we provided patients with a letter of notification that anonymous data was being collected from their charts to answer a clinical research question. They were also provided with the information necessary for them to remove their information from the trial database if they so chose. In developing our consent model and our patient-facing materials, we engaged with a number of people with lived experience of cardiac surgery and delirium, as well as several other stakeholders. While patients consent to surgery, they don't normally consent to anesthesia or the individual elements of anesthesia care. Given this, as well as the importance of our clinical question and the potential benefit to the common good, all of our stakeholders uniformly felt that our approach was reasonable and did not compromise public trust. As mentioned, we provided all patients with a letter of notification that anonymous information was being collected from the charts of all patients having cardiac surgery within each participating hospital in order to answer a clinical research question. Patients were told that if they so chose, they could request that their individual data be removed from the trial database. The content and language within the letter was informed by feedback and guidance from our patient collaborators in alignment with the guidelines provided by our Research Ethics Board. The trial was endorsed by the Perioperative Anesthesia Clinical Trials Group, who felt that this was a very important question to inform the conduct of cardiac anesthesia and cardiac anesthesia practice. Further, as mentioned, we engaged several patient partners early in the trial design stage before we had even conducted the pilot study. Their feedback and advice was absolutely instrumental for the design and conduct of the trial. Indigenous people in Canada are frequently affected by coronary artery disease and valve disease, but are often not included in cardiac surgery trials. In conducting a trial where we randomized institutions rather than patients, we generated results that could be applied to all patients undergoing cardiac surgery. With respect to data sovereignty, we only collected data that was documented within routine clinical care and, within our centralized trial database, did not collect any patient identifiers. Patients were never directly approached by trial staff, but were notified by letter that their anonymous data was being collected and were given the opportunity to withdraw their anonymous data from the trial database within a certain time frame. As mentioned previously, adherence to the randomized policy was a key element needed to ensure the internal validity of trial results. As such, during the first week of every crossover period, we required sites to provide daily adherence reporting to our central coordination office. Provided there were no issues, this decreased to weekly for the remainder of the period. In cases where adherence lower than 90% was identified, we engaged with sites immediately to determine the cause of low adherence and, where needed, rectify the issue. We used a hybrid model of data collection according to resources available within each participating hospital. In hospitals with EMRs, or electronic medical records, data for the trial was often extracted into Excel sheets and then uploaded into our central database. In hospitals without electronic medical records, research staff manually extracted data from patient charts retrospectively and entered it into our trial database. Our trial team had excellent representation of many stakeholder groups and individuals from diverse backgrounds. Because we included every single patient having cardiac surgery at each of 20 participating hospitals in North America, our results can be generalized to all patients. However, because ethnicity and gender are often not documented in routine medical documentation, or if they are documented, they're often not reported by patients or inaccurate, we were unable to conduct subgroup analyses examining these specific subpopulations of patients. By integrating our research question into routine clinical care, we didn't change care at the level of the individual patient. We just standardized it at the level of each participating institution. As such, the costs of conducting the trial, including patient enrollment, data collection, and central coordination, were substantially lower than those of conducting an explanatory trial of similar size. The total cost of the trial came to about $850,000 Canadian. In contrast, an explanatory trial of 20,000 patients would likely cost roughly $20 million Canadian to complete, if not more. Thanks for your attention and for the opportunity to talk about the Be-Free trial. And good luck to all of you in designing and conducting the pragmatic research that you're being taught how to do.